would like to welcome everybody to today's webinar, What Providers Need to Know for 2018 Ambulatory Reporting for MIPS in Stage 3. And my name's Scott Mash, and always I'm joined by my partner and friend, Miss Cathy Costello.
Hey everybody, thanks so much for joining us. And I have to tell on Scott and me, we were doing a webinar for the hospitals yesterday, and he had purchased a new microphone, and it's so sensitive that we were talking so softly so it wouldn't overdo. And Cathy Rich told us we sounded like dead ducks at the end of it. So we've moved the microphone all the way to the other end of the room. But if you're having problems or we ping or anything, just go ahead and message us, and Cathy's going to be watching for it, and we'll try to adjust it. But anyway, so hopefully it won't be a problem today. Before we roll on what's going on in this year, 2018, I do want to tell you, because many of you were involved in helping gather comments when we commented on the regs for last year, and we had pretty complete comments, and as a result, CMS has approached us about doing a review of how MIPS worked in the first year, and our specific expertise that they're asking us to talk about is the improvement activities area. And so I'm just asking you, if you have any thoughts about it, if you have questions or problems you had in documenting improvement activities, if you have new areas that you would like to see added, or just general thoughts about the process, and you can send it to us sometime in the next week. We're going to be participating in about 2 weeks in this CMS review. And send it to, you notice it's Cathy Rich's email, because that way I'm sure it'll get addressed. so please feel free. And as always, if there's anything else you'd like to comment on, do feel free. And when this year's regs come out, we'll let you know. So to begin with where we are, it took until November to get all the regulations released that you are operating under for this year. And I think Scott and I were afraid it would they'd never come out. I mean, we kept saying, oh, it's going to be, and we kept hearing from Washington, oh, it's next week, you know, it'll be next tomorrow type of thing. And they didn't actually release the physician rules until the first week of November. And so there's a lot that people are still kind of assimilating, because the interesting thing, you don't often see this, but there were some significant differences between the proposed regulations and the final. And so it is something that you do want to review. And just to kind of give you a couple general high-level perspective that we had on these regulations, there seems to be what I call big categories that CMS was addressing, and some things that they did not address at all or did not really change. The new areas that they were addressing as category is virtual reporting, which is combining with people from around the country into a group for group reporting. And trust me, we do not know very many, if any, people in Ohio who are involved with virtual reporting. Everyone's either responsible for themselves, or they're part of an ACO, or they're part of a group. So, but that was one of the big areas. The other big area that we'll be talking about when this next set of regulations come out is CMS is starting to push in the regulations. This is now the second year they mentioned it, the question of an all-payer ACO. So what they're trying to do is to get providers to start looking at doing a combined alternative payment model that would cover not just your Medicare Part B patients, but maybe Medicare Advantage and maybe Medicaid and some private. So they are lining up. They spent quite a bit of time talking about it in this reg, and then saying that they would address it in the regulations that they're going to be releasing as proposed regulations in about 3 months. So be thinking about that. Nothing you need to decide now, but do want you to be aware that that was a major thing for them. And to give you an idea of how the process is working, the number of shared savings programs, ACOs for Medicare, were 480 this year, and which is 16,000 different tax IDs were involved in ACO reporting. So that is pretty significant. And I know Ohio has become a big ACO state. So that is something you want to keep an eye on as these new payment models come out, if it's something you want to be involved in. CMS anticipated 622,000 providers reporting under MIPS for 2017, and over 200,000 reporting in one of these new alternative payment models, and over 500,000 physicians are going to exempt out due to low volume. And the financial amount is $118 million is supposed to go towards payment of incentives in 2018, and up to 500 million for the extraordinary performance. So we'll see how that works, but that's kind of just the snapshot of where CMS was with all their information. Coverage for MIPS reporting is the same as last year. FQHCs and rural health centers are exempt. Method 2, if you're in a CAH or small rural hospital and you're doing Method 2 billing, you are covered under MIPS. Locum tenens are not covered under MIPS. There is a change here. Now, this is one change this year, and it was a change from the proposed to the final. So you want to make note of this if you had heard discussion about it. When CMS originally proposed these rules, they were going to hold the weighting or scoring bit, W-E-I-G-H-T, weighting of the various aspects of scoring the same, where it'd be 60% would go to quality, 25% would go to meaningful use or ACI, and 15% would go to this new improvement activity. And that is true for everyone except for the alternative payment models. We'll talk about that separately in a minute. But in the final reg, this was something that showed up without a lot of discussion in the finals, and that is that they've decided to actually, as part of your scoring for MIPS in 2018, is they are going to include cost information, and they were not originally planning to do that. So the way that looks is that they reduced the quality scoring to 50% of your overall composite performance score. And I'm sure you all recall the composite performance score is, or CPS, is the number that you get when you do all your various activities, whether it's quality, ACI, improvement activity, roll it all up together with your performance, and gives you one overall composite performance score. So what this is saying, in 2018, you're still going to have those three areas, quality, ACI, which is technology, and then improvement activities, but you'll also be judged on your cost, and the cost figure comes out of your Medicare Part B claims. So that's something that you may not know in advance, where you fall in relation to national benchmarks. But the two areas that fall into the cost category are the Medicare spending per beneficiary and total per capita costs. Now, does that sound familiar or not? Now, those of you who have listened to Scott and me lecture on this for the past couple of years, those are exactly the same figures that showed up in your QR/UR reports, the cost quality reports that every tax ID can draw down every single year. So this will continue to show up. It's just going to show up in a slightly different report, but same identical things. How much does it cost to have your patients hospitalized for an episode of care, and how much is the overall cost of your patient in a given year? And I know you're not responsible for all those costs, but the reality is you get judged on it. So that's what's going to go into your cost figure, and that will be determined by claim. The same thing I can say is on the APM or alternative payment models, that these figures are going to adjust. So we'll talk about that separately. As we started to talk about on the composite performance score, that your goal is, it'd be great if you get 100% on everything, but the reality is most providers are not, and especially now that you're throwing the cost figure in, where you have less control over it than you might on the other three categories. You're still trying to score 70 or better. Now that has remained constant from 2017 to 2018. 70 or better is your exceptional performance category, and where exactly CMS is hoping to pay you more money. You are hoping that CMS will pay you more money. This is the chart. Again, this goes back to what was originally released a couple of years ago on what MIPS would look like. And that blue arrow at 2020 is where we are right now. So 2020 is the payment year. So it is based upon 2018 performance year. So as you can see, we have now increased the potential, what I call the base bonus, it increases from 4 to 5% to expect in 2018. The potential penalty, if you do no reporting at all, is a -5%, with a maximum of being 15%. And I would not hold my breath for the 15%.
Yeah.
What do you think, Scott?
Well, I agree, because just keep in mind, this is a budget neutral program. So for there to be winners, for you to get the 5%, somebody has to get the 5% penalty. So without losers, there are no winners.
Right. And notice that last column is the advanced payment model, advanced APM. This is not Medicare shared savings. This is not a Medicare ACO.
Risk bearing.
Because that's a little bit different. That's handled as MIPS providers, but it could be stuff like CPC Plus. It could be a risk bearing ACO. There are a number of models that are covered under that, but those are the flat 5%.
And the new BCPI model as well.
Right. Yeah, and we'll have to see when that gets going. So we'll, if they participate in the first wave of the bundled payment, they would not actually be eligible as an advanced ACM in 2018, but would be in 2019.
That is true.
So what's the impact of all these numbers that CMS is throwing at you? Is if your score, your composite performance score, as we said, 70 or above, is, and you can notice in this bottom line down here, 70 and above is related to getting the 5% plus the exceptional performance. If you're between 15 and 70, you could get anywhere from 0.5 all the way up to 5%, depending on the budget neutral aspect. 15 is your, what I call your baseline. You want to score at least 15 points to avoid a penalty. This is different from 2017, when it only took 3 points to avoid the penalty. Now you have to get 15 points, and that can be a combination of quality, it can be just ACI reporting, it can just be improvement activity. You can decide how you want to do that if all you're interested in doing is to avoid a penalty. But anything below 15 is going to get you a penalty. Okay, there are some big changes this year in what I call eligibility changes, and we're going to look at the small physician practice in just a minute separate. But there is a low volume exclusion that has changed from 2017. There are also a new proposal, not proposal, but actual program for what I call small practice provider bonuses. Again, we'll look at that in just 1 second. And as I said, you do need to receive the 15 points, and there are changes in the definition of hospital-based. So hospital-based is not just inpatient, not just ED, also is outpatient billing, so POS 21, 22, 23, and now 24, the ambulatory surgery centers. And the ambulatory surgery center provider will not have to file ACI information for at least 2 years, and they can just report their quality and report their improvement activity. Okay, so let's look at the small practice, because I think this is an area that CMS clearly was trying to address in these regs. They had a lot of pressure from Congress to do so. I don't know if you've heard about the Cures Act, but it was this huge bill, a piece of legislation that was voted on at the end of 2016 that is shaping everything that is being done in the healthcare area now for the last several months. And the Cures Act, besides giving additional funding to research and to orphan drugs and some other areas, it also had told CMS to make sure that they did more things for small practices. So these regulations are really done to address what Congress was saying to CMS. So they have created a new category for small practice. First of all, the practice size is the same. So it's 15 or fewer providers who billing Medicare Part B are considered small practice. And the reason that they look at that is to determine whether or not you're going to be eligible for some of these bonuses and whether or not you have to report. So if you bill less than $90,000 or less Medicare Part B, either from September 1st of 2016 to the third quarter of 2017, so that's their look back period in determining your billing, or looking ahead to current billing, September of 2017 through August of 2018. So 2 periods of time will determine your eligibility under a small practice. And if you are billing less than $90,000 during that time, or you are billing less than 200 Medicare Part B beneficiaries, not Medicare Advantage, but Medicare Part B beneficiaries, less than 200, either one of those tests puts you into an exempt category. Remember how we said that over 500,000 providers may be exempt due to the low volume exclusion? These are the specifics of that.
So if you're determined to be under the threshold for either of the 2 evaluation periods, once you're exempt for one of them, you're exempt from the program. So it's
correct.
2 different looks.
And this is another place where the proposed and the final reg look different, because in 2017, small practices that were running were less than the exempt amount, which at that time was 30,000. It's now been increased to 90,000 in billing. In that particular area, in 2017, if you fell into this low volume exclusion, you did not have the right to report and expect bonus anyway. You were just automatically exempt. You could report, but you received no bonus for it. In the 2018 proposed regulations, they were going to allow these small practices that were eligible for the low volume exclusion to report and be eligible for bonuses, but in the final draft, they reverted back to the 2017 approach. So what they're saying basically is if you bill less than 200 Medicare Part B patients during the eligibility period, or you bill less than $90,000 in Medicare Part B approved claims, then you will not be eligible for the MIPS bonuses. As I said, you can report, and it may be that you cross this threshold under group reporting, in which case you then report. But if you're reporting either as a group or individually at less than these figures, then you are not eligible for bonuses. The small practice bonus is something brand new. Brand new. They are doing it in 2018. They have not committed to doing it moving forward. My guess is that they will do it probably at least another year after 2018, but it's clearly a 2018 legislative initiative to help small practices. And what this is if you are a small practice determined at less than 15 or less providers, and you are eligible to report under MIPS, then in your scoring, remember how we talked about the composite performance score, rolling up your quality, your cost, your technology, ACI reporting, your improvement activities. When they roll that all together and you determine what your score is, if you were one of these providers in a small practice setting, then you automatically, CMS adds an additional 5 points to your composite performance score. So it's just another way of helping small practices reach that extraordinary threshold, so that hopefully you can get the additional funding for the year, which in 2018 would be 2020 billing. So that's one way that you can increase your payment as a small practice. The second way is complex patient bonus. We're going to spend a little bit more time on the next slide about that, but I'm just saying that the one doesn't negate the other. So if you're eligible for a small practice bonus and you have a complex patient mix, you can be eligible for both of those bonuses in the same year. If you decide not to file for ACI, which is meaningful use, and you, for whatever reason, you haven't adopted it, you're not meeting the measure, whatever it is, the CMS will automatically re-weight your categories rather than giving you a 0 here, which would negatively impact you. They just judge you on the 3 remaining categories. So it's in an effort to make it easier for you. You would not have to do a filing for this. CMS would tell you whether you fall into this category. And then quality, if you submit your quality and you don't have data completeness, you don't have enough patients, but you've submitted information on it, CMS is still going to give you 3 points for each quality metric that you submit as the base. I mean, you may obviously score better than 3 points, but you'll have a minimum of 3 points if you submit any quality on your patients during that time. The complex patient this is one that is important to everyone, whether you're in a small or large practice, because it's a change in approach for CMS. And so what CMS is doing, and this was in response to a lot of comments, is that people were saying, hey, look, you know, we don't score as well on some of this stuff. We don't score as well on quality. We don't score as well on what used to be our meaningful use measures, because we deal with a very complex patient base. It may be a high Medicaid base. It may be other very needy patients, whether it's end-stage renal disease, you know, whether it's very chronic condition oriented. There are many, many practices that have these patients, and you all know what we're talking about. They're high-risk patient load. And so what CMS is going to do in 2018 is they're going to look back at the claims, and they're going to look at what is called the HCC risk score, which, again, if you remember your QRUR reports, every patient is assigned a risk score based upon the chronic conditions, based upon their age, based upon socioeconomic factors. There are a number of things that go into that determination, but they're assigned a risk score. So you, when you're working with your patients, you know who's at higher risk in CMS's eyes. So CMS is going to take that plus the determination of whether the patients are dual eligible. So are they a combined Medicare, Medicaid patient base? So these 2 factors go into determining whether or not your patient mix is considered a complex patient mix. If your patient load is considered complex, then CMS does this little calculation. You can see it right there. And then they will add whatever the appropriate bonus is onto your composite performance score to recognize the fact that you have these complex patients.
So pretty much every provider out there could see a point or two from this.
Correct, and it's all done as an algorithm. It isn't something that you calculate. CMS calculates due to with looking at your claims. Other changes are for those of you who are in an ACO, especially Medicare Shared Savings. You know that in 2017, CMS made a little neglected to add something, and that was when they were looking at who your providers were for determination of ACO participation. They were looking at 3 times a year: the beginning of the year, the end of the first quarter, the end of the end of the first quarter, second quarter, and third quarter. But they weren't looking at the fourth quarter. And so if you had new patient or new providers coming into the ACO during that last quarter, you had to figure out a different way to report for them. CMS corrected it in the 2018 regulations. And so now everyone is, all the alternative payment models, they're looking at that end of year reporting also. So December 31st, 2018 is going to be the last determination for deciding who your providers are, or whether or not they're QPs for the alternative advanced models. The other thing for APMs is your scoring looks a little bit different than the normal MIPS provider, in the sense that you will be judged 50% quality, 20% in improvement activities, and 30% of your technology or ACI reporting. So it just looks a little bit different on your percentages. The other thing that is different with your alternative payment models, and pay attention here, because even if you aren't an alternative payment model, this is the handwriting on the wall for the rest of you in 2019. CMS talked about this in the proposed reg and then peeled it back to only cover alternative payment models and not all providers. And that is, how do you reward a provider for improvement? So you're rewarding everyone basically for how they score on stuff right now, but you aren't looking at how their quality is improving. And so CMS had looked at a couple of different ways of doing this, and they settled back on what is now the easiest way, but they will be looking at it over time. And what they said here is that the alternative payment models have a certain set of quality metrics that they need to report on, and it's set for every year. And there's like 32 metrics, but basically between 15 and 20 of what we call the normal quality metrics, you know, preventive health care, cardiac, risk of fall, you know, closing the referral loop. There's some very standard ones that you report on, and you report every single year. ACOs do not have the opportunity to select their quality metrics. They're being told what to report on. Same with stuff like CPC Plus. So CMS is saying, okay, we know that you have the same quality metrics every year, so it's going to be easy for us to judge whether you've improved. We can look at your score last year on your flu immunization figure, and we can look at it this year, and we can see if you improved. And so that is what CMS is going to do with the alternative payment models, because they have certain standardized reporting that they're doing. I do anticipate the modeling for including improvement will come in 2019. It's just that CMS had to figure out how to score everyone else who might not be reporting the same identical quality figures in 2 years successively. The other thing that I'm sure you're aware of is that if you decide to do CAHPS reporting, which is the patient satisfaction surveys, it is scored as a quality improvement, is quality activity. Okay. The other, just a few quick notes on changes here. All condition readmission for larger practices is included as a 7th quality metric. You don't report on it, CMS puts it in. The data completeness is different, higher this year than it was last year. Again, this is a change. Last year in 2017, you were considered as meeting the data completeness if you reported on 50% of all your patients, 50% of the quality for all your patients for a given quality metric. In 2018, this rises to 60%. The other difference, and this one I have to point out because I know providers who are reporting differently, is that in 2017, you could report 90 days of quality, like you could with your 90 days of ACI. In 2018, you can continue to report 90 days of ACI, but you are going to have to plan on a full year of quality reporting. So you're reporting on 60% of your patients in any given quality measure for the full year. Data submission stays the same, and we'll talk some more about that, but the important thing to note here is that for the areas that you submit for, ACI, CPIA, and quality, you have the opportunity to submit through a registry, through claims, and I was really interested to note on claims, there are more providers that do their quality through claims than any other form of submission. So quality, registries, claims, EHR, which is you load a report from your EHR directly to CMS, or through the CMS web portal are the various ways. I would make the point on group reporting because this was kind of a new option last year in 2017, so people were just getting comfortable with it. But please note, there had been a lot of discussion in the proposed rules to allow what I call a more sophisticated approach to group reporting, where you could do like subgroup, you know, if you had some providers involved in CPC Plus in a tax ID, you could do them, and then you could do everybody else separately, and on and on. The way that they ended up with the final rule is everything stays the same as 2017. So if you report as a group, you include everyone in the same, under the same tax ID in your group reporting. You can use different mechanisms to report quality, ACI, and improvement activities. So you can report directly to CMS, or you can go through a data registry or whatever. But every provider in a group must be, you do one submission regardless of how you're doing it. So you have to stay with the group. If you decide to report one thing as a group, you report the whole ACI, CPIA, and quality as a group. If you report as individual, you stay with the individual reporting on all three areas. The one thing that we'd say, and Scott and I got burned on this a couple times this year, is, you know, we'd help practices look at their physician status to see whether the practice provider was exempt from MIPS reporting. And we checked it all. I must have checked hundreds of providers back in like May of 2017. What we found the hard way is that CMS was updating that QPP website. I don't know how often they did it, if they did it weekly, monthly, or whatever, but they were getting the bugs out. They were adding categories. They were changing the status. And I just, you know, kind of a heads up, I anticipate some of this newer stuff like small practice bonus being listed now on the QPP, but just be assured that you're going to want to check more than once, and probably later in the year rather than earlier.
Yeah, they definitely update it when they do the reevaluation between the two periods.
Right at the end of August, they definitely would have another upload of information. So just keep that in mind. Okay, I'm going to turn over to Scott for technical, and then we'll move on with a couple of the other things.
All right. There's a lot to consider for 2018 for organizations, for your, you know, when looking at your EHR, you got to kind of step back, take a deep breath, and think about what's best for the organization, what's best for your team. You know, consider when you're going to take your stage 3 upgrade, when you've contracted with your EHR vendor to take those upgrades. What's the status if you're in a large healthcare organization, or if you're in an ACO? What are your affiliated groups doing with their systems? And with some large organizations that have 2 or 3 different EHRs, they'll have a specialist EHR. You got to consider those as well. Is it better to knock out your stage 2 reporting period in the first 90 days for your ACI, wrap that up, put it on the shelf, and then focus on stage 3, or jump right in with stage 3, work out all the bugs, get everything in place, and then do a stage 3 reporting period later in the year for your ACI? And again, also consider your quality's full year. So whatever you're doing to your EHR, you might have to ensure that you don't have an impact on your quality reporting. Also, talk to your vendor about API functionality. Remember, your portal now, it's view, download, transmit, and API. You've got to have that API functionality out there. How's your vendor implementing that? Who have they partnered with? What applications are available? You also have to consider those new measures. We're going to talk more about those measures, but the one that's called non-clinical data or patient-generated data. How is this information going to be captured within your EHR? How are you going to keep that from cluttering up the core clinical record? And also, you got to consider for your connections to the HIE, because there's the one measure, and again, we're going to talk about these more here in just a second. But when you receive a new patient, you have to check. You have to search for patient information. Well, the right way to do that is to search the HIE. Are you set up with that functionality? Is this a year that you're going to take on electronic prescribing of controlled substances? If so, how does that impact your stage 3 implementation? When are you going to adopt appropriate use criteria? Appropriate use criteria, yesterday's webinar, I incorrectly stated that it was required January 1st of 2019, when in fact, it is required January 1st of 2020. You can do it in 2019, you get extra credit. It's actually an improvement activity under MIPS that gives you an ACI bonus if you do it early. And there's some benefits from doing it early as well. So 2018 is another kind of confusing year when you're looking across your organization and the reporting programs that you have to work with. And it looks a lot like it did in 2017. For your Medicare eligible clinicians, it's a 90 days for your ACI, a full year. The measures are the same as they were for 2017. Of course, it's a very inclusive groups, MDs, DOs, NPs. You see the list here. And don't forget, if you have those Medicaid physicians or providers that still have some dollars left, you have to also attest to Medicaid. Medicaid's very traditional, meaningful use that includes the CPOE measures. Same thing with regards to stage 2 or stage 3. You can do either or a mix. Again, you have to, the old eligibility rules with more than 30% do apply. And in alignment with MIPS, your meaningful use reporting under Medicaid is 90 days. Your quality is a full year. And then the hospitals are doing the same thing they did last year. It's a 90-day reporting period. They have the ECQM requirement. They do not have the CPOE or CDS rules anymore. You can do stage 3, you can do a mix, but you have those 3 public health measure requirements. So the folks out there that have been able in the past to exclude from ELR, not have to worry about that 3rd public health measure, we probably need to dig in and take a look at those specialty registries. Right. Yeah, and again, that's only for the hospitals. But again, we'll for those folks we work with, we'll focus on that this year. So again, let's just take another different view of what the technical requirements are. In 2017, you reported your ACI under MIPS. It was 2014 or 2015, 90 days. 2018, it's 90 days. And again, it's 2014 cert, 2015 cert, or a little bit of both. If you are fully 2015 cert, you can still attest to the stage 2, just like you could last year. So again, it's a minimum of a 90-day reporting. You can report a full year. Quality is a full year. Now in 2019, we don't know, because the way the regs read is we might do 90, we might do a full year. We'll get back to you on that one.
And they said last year, a year ago, they said that they were definitely doing in 2019 that the physician ambulatory providers were going to be 90 days. and they backed off of that, and so that's a big question mark. So both for the hospital and physicians in 2019, we don't know whether or not you're going to have to be ready on January 1st with your stage 3 or not. So we'll let you know that when we stay tuned when we see the proposed regs.
Well, yeah, and it might say one thing in the proposed regs and go back on the final regs too. So
that's true.
We'll keep our ear to the ground on that one. All right, so now let's talk about the stage 2 measure. If you decide to stay with stage 2, again, it looks exactly like you just wrapped up for 2017. There are the 4 measures that you're required to do under ACI to receive what's called your base score, and then they calculate your performance score for the last 50% based on how you do on those on the measures. Now you'll see the ones here in red are the ones that are required for base score. There is an exclusion if you're under 100 prescriptions. You can exclude from ERX. If you're doing the if you have less than 100 referrals, then you can exclude from the HIE and still receive your base score and then work towards that performance score. So keep in mind, there are no minimum thresholds for the measures. You got to get at least 1 in the portal and whatnot, but the better you do, the better your score. And again, you get a bonus just like you did last year for your immunization and your public health reporting and improvement activities, which we're going to talk a little bit more here in a little bit. Now, these are your stage 3 measures. And if you go to stage 3, there are 5 measures that you must get something in or you must score in to get your base score. And really the only thing they added that's different is the request accept patient record. So it's the 4 that we had previously plus that one. And the 2 exclusions, the one for ERX, the one for outbound referrals, still apply. The math's a little bit different, but it pretty much, the scoring works about the same way. Now, let's talk about the new measures. Under coordination of care, they kind of group together your 2 portal measures, which are the VDT and secure messaging and health data incorporated. And that health data incorporated, that's that patient generated or non-clinical data. How are you incorporating that back into your EHR? So we have that new category. We also have the health information exchange category, which is the old one where you're sending out your outbound referrals. The 2 new parts to that are request or accept. In other words, when you get a new patient, did you receive a direct message for that patient? And if not, did you query an external source? Did you query the HIA to see if patient information is available? It didn't say whether, it doesn't require that there be information available, only that you ask. So if you query the HIE and it says, I don't have any information on Bob, you've still met that measure.
Yeah, and as we said, you don't have to meet these new measures in 2018, but if you decide to report on it, or once you get your stage 2 measures in place, we'll be doing webinars probably about mid-year to talk about these new areas and go into more detail about how you can meet these new things, how you can use different tools, what's available, and stuff like that.
And you also see the 3rd one there in the health information exchange is clinical information reconciliation. That's just an expansion of MedRec to also include problems and allergies with medications. So again, take a deep breath. Think about your organization, what's best for your organization. Your attestation period for everybody for the ACI measures or meaningful use if it's Medicaid is 90 days. You can use stage 2, you can use stage 3, you can use a mix. And this is true in a group as well. Think about your larger groups where you might have 2 EHRs, you might have 3 EHRs. You know, you can use a mix of different technologies as long as it's at least stage 2 technology or 2014 certified. Now we're going to shift over. We're going to talk a little bit about improvement activities because we've seen some changes here as well.
Oh my gosh, just major changes, because this was the newest area that CMS introduced in 2017 was this whole concept of improvement activities. What are you doing at the practice or the organization level to adopt best practices. And then CMS had come up at that time with about
90.
60 the first time, then it moved to about 90. They've now added another 27, I believe, new activities that fall into this, or 21, and they modified 27. So we're going to talk about that a little bit more, but let's start with the ones that are what we call the bonus categories, the bonus improvement activities that will give you what Scott was just mentioning in your ACI score, will give you 10% bonus points merely by reporting that you're using technology in one of these areas. So we have the first 15, which I'm not going to go through right now. You should be familiar with that because you were working with them in 2017 to find one that would give you those 10% bonus points. But
yeah, there are actually 18 that are holdovers from last year, or ones that we've seen before.
Right.
That get the ACI bonus.
But here's the new ones. We have another 15 that are now being added. And let me just kind of get you to think at a higher level about these. One of the priorities CMS has this year is prediabetes screening. Huge priority. You saw this in the physician fee schedule. They spent almost 500 pages laying out a new program to pay for prediabetes screening and these new programs that are being set up. They're basically health and wellness for prediabetes, patients that are at risk but not truly diabetic. So there's a couple of these new measures that go to that you can pull off as part of the 10% bonus for ACI reporting.
You also see a couple in here. Another big focus is the social determinants of health. So you see these links to community resources and practice improvements using community resources. Those are really to address those social determinants of health. Do you have a means of hooking a patient up with the local food bank or with other needs? And this is really embracing the medical neighborhood concept as well.
And you see several of these go to specialists, perioperative surgical homes, and areas that are more specialty oriented. And note the one that Scott had already talked to you about, consulting AUC, appropriate use criteria for ordering diagnostic imaging. That gives you a whole new bonus category here, and it's high priority.
Yeah, that's a high weighted one as well.
Right. And then we have other ones that have to go, that go to more patient care, chronic care management.
Patient-reported outcomes, yeah.
And definitely behavioral health. So look through those. And what I would say, the thing I'm going to say now with these, any of these improvement activity, make sure you go back and read it. We were so frustrated in 2017. We thought we knew the improvement activities big time. And what we found is that CMS decided halfway through the year to change the language on some of them. When they showed up on the website, they weren't.
One worth noting is that one that's called use of HIE. It was defined one way in the regs, but then when it shows up on the website and in the final reg, it's a bi-directional. So it's not only are you using an HIE to pull down, but are you contributing data as well? So that's one that we've definitely seen change, and many are just vague.
And they have, oh my gosh, as I said, they have 21 new ones, but they modified 27, a good third of their current improvement activities had some type of modification. And they changed the weighting on some of them. So some of them were high priority and they moved them to medium, and a number of medium, quite a few medium, they moved to high. So you want to check that when you just are trying to plan your year as to what improvement activities you want to be engaged in. The other big change in this area, and this affects a lot of people in Ohio, is that in 2017, if you listed PCMH as a reason to get full credit in improvement activities, you only needed one site. You actually only needed one provider who was engaged with PCMH to be able to claim it for the whole tax ID that you were reporting for. This year, in 2018, you now need to show that at least 50% of the sites reporting under that tax ID are PCMH certified in order to claim that as an improvement activity.
And that's 50% of the sites, not 50% of the providers.
Right. The other thing that you want to know is there was only one improvement activity that was removed. It took us a long time to figure out which one it was, but it's if you participate in one of these new improvement models, such as Million Hearts, it no longer counts as an improvement activity. And we won't go into all the reasoning that they did, but just be aware of that in case you were using that. The reporting period for improvement activities will stay at 90 days in 2018.
There's 1 or 2 measures that are 6 months under those.
Right.
Yeah, so it's 90 days for almost everyone.
Right. Again, just be aware of it. And then again, you can report improvement activities through any mechanism that you're using for your quality reporting. And just keep in mind, improvement activities are just a yes/no question on your attestation, but you want to make sure that you have all the documentation in place in case of a future audit. Okay, quality, just real quick note on quality, because most of this you have to track back to CMS's site or their spreadsheets for the measures for this year and the decile scoring for it. But the general rule is you will still, at the individual or group level, if you're not part of an alternative payment model, you will still be reporting 6 measures, no specific requirement for domain or cross-cutting. Shared savings will have its own specific measures, same that they have for a while. If you're in an APM, your scoring is linked specifically to the quality that you report under that alternative payment model. You still must have 1 outcome or 1 high priority measure. And you have to report as a group. If you're doing ACO reporting, it's required to do group reporting. The CAHPS patient satisfaction survey will count as 1 quality measure. So with that, another issue with quality, here are the quality measures that have been removed. If you note, there are a number that are actually related to hospital type patients, but just be aware of it, including the bronchodilator therapy for COPD. You're going to start seeing, they didn't do this in 2017, but starting in 2018, you'll see what will happen is these measures that they're calling top-down will be, they're ones that are, I forget, it's 90% or 75% of the patients practices and providers report 90% or greater compliance. So that's their definition of top-down, and they will start removing these measures every single year, and it's a 4-year cycle. So there's a notice period, there's a collection period, a notice period before it actually gets removed. So you do want to be aware of this each year to see what the measures are that are topped out or that are being removed. They will allow maximum points. They will give you points for topped-out measures, but it will be no higher than 7 points for each topped-out quality measure this year. And then the very last note before we get to our questions is this is something you may have heard us talk about under the proposed rules early in the year, that CMS had a very elaborate plan in 2018 to allow hospital-based physicians, true hospital-based, where they're billing in the inpatient setting or the ED, that they could report their quality as part of the hospital's value-based purchasing quality reporting program. So surgeons would be covered, hospitalists would be covered in this way. Just be aware that this proposal was removed from reporting for 2018. They are talking about bringing it back again in 2019, but right now, physicians cannot report under the hospital's quality reporting. They must report under MIPS or one of the alternative payment models, depending on what they're involved in.
And again, what this really meant is the proposal or the thought was that when the hospital submitted IQR, that covered those hospital-based physicians. We're kind of hoping to see this come back again in the proposed rule or something similar. And I believe it'll come back as they expand the number of ECQMs that are required to be submitted under the IQR program. We'll probably see this raise.
Well, I'm sure once we see the proposed rules, they're usually out by, I'm going to say May or so, May or June on the physician side. And we will be looking at it, and we'll probably end up doing a webinar over the summer, just so you know what's being proposed, and you can look at some of this. So with that, the other thing before we get to questions that I want to say is the number one new initiative that CMS has in 2018 is prediabetes screening. The whole area of prediabetes treatment and screening is CMS's greatest priority. They did studies in conjunction with the Y. They did 5-year pilot studies, and basically they showed that 60% of the patients could be prevented from becoming diabetic by participating in these health and wellness programs. That figure rose to 75% for those in the Medicare age population. That is why you will see starting this year in April, CMS is going to start paying the full cost of participating in these health and wellness programs that have been certified by CMS. So if you need more information, look to our website. We've had a lot of information in articles about it and webinars. Or we'll be more than happy to work with you. It is a high priority for the state of Ohio. In fact, today, the Ohio Department of Health has released a study to the Ohio legislature about diabetes in the state that includes information on this. And again, we'll be sharing that with you. So with that, let's go to questions.
All right, let me pull up the questions here. Ooh, we got a few questions. All right. Sorry, guys, give me just 1 second here. All right, question 1. If reporting ACI as a group with QPP portal and adding our numerators and denominators from our EHR for each measure, what would happen if there are duplicate patients reported because they may be counted for more than one provider under a group? And that's okay. ACI is different than your quality. Under quality, it's kind of centered around the patient. Did the patient get the testing? Did the patient get their flu shot? Did they get their A1C? Under ACI, that's focused on the provider. Did the provider do what they were going to do or were supposed to do? So let's say patient Bob goes to their primary care provider, that primary care provider is judged on how they enter the information in the EHR around the portal, VDT, all that. Did they provide patient education? When they send that same patient over to a specialist, it's the same thing. It's how did that specialist take care of that patient within the EHR? So you're going to see patients show up in the numerator and denominator, the same patient, for multiple providers. ACI is easy. You add together your numerators and denominators for all your providers, for all the measures. You're going to have duplicates because it's a different look. Did the provider use the EHR in a meaningful way? So pretty much that's how it works under the ACI scoring. Any update on therapists being required to participate in 2019 and beyond?
That's funny you should mention it. That was actually one of the things that I was digging through the regs yesterday and this morning to see if there had been an update. I saw nothing in the 2018 regs. In 2017, they laid out a kind of approach to glide path for adding therapists to the MIPS reporting, and that was a totally different issue than the QPs, the who's covered under bonus for alternative payment models. There was a huge list of providers there. But on the question of MIPS reporting, they did not increase it or expand on it. So I'm going to ask for clarification on that. But without any further clarification, the 2017 proposal would stand, which is to expand that to psychologists and social workers and stuff, I think in 2019. I'm anticipating getting a lot more information on that with the proposed regs for 2019.
Any suggestions for a private practice that's having a hard time obtaining direct secure email addresses for other EHRs to increase our numbers? It's very difficult. Are there been any changes? Well, if you join the CliniSync HIE, there's no cost to join the HIE, and by doing so, you would be eligible to receive our list of direct addresses that we've collected from around the state. There's been a lot more organizations come online with direct addresses. Folks are starting to understand what you mean when you come up and say, hey, what's your direct address? Really, there's no change to the requirements or another way to provide you with credit for those outbound other than sending via direct. I would kind of hope that would change. Don't forget there's that improvement activity as well for the bi-directional sharing of data, pull data down from the HIE and share data with the HIE. Yeah. But really for those outbound referrals, that's the only way to do it.
Yeah, you can send us an email if you want to follow up, and we'll have someone contact you in your area.
Can a group practice report as a group if they are using different EMR systems? For example,
we spent a lot of time on this one this year with CMS.
Yes.
And the answer is yes, 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 you can. Yep. And I'll tell you how they say to do it. We thought it was going to be a very complex thing where you had to combine your patient base and stuff. And the reality is CMS said, and we've got a couple of emails to this effect, you just add up your numerators and denominators across the different EHR systems.
For ACI.
For ACI.
Quality's a little funky.
Quality, you have to have that level 3 report unless they allow for attestation this year.
Yeah, and I don't know.
We haven't seen that yet. So.
Yeah, but again, the quality of those, remember, it's centered around the patient, even if you have multiple EHRs. So you might have to involve for multiple EHRs, you're probably going to have to involve a registry to help you out with that, to combine those.
Yeah, unless you have a tool IT that can do is you need a QRDA level 3 combined file from the different EHR systems.
Okay, from slide 21, what advantage would there be to taking an exclusion for HIE and ERX if you can get credit for at least one in the numerator? Really, that is there for those rare cases where you would have a provider, let's say a surgeon, who when he's doing his surgeries in the hospital, he does his scripting in the hospital setting, but then does the follow-up in an office visit, but never writes scripts in there. Just doesn't do it as part of his practice. They would not be eligible to receive a performance score without that ERX exclusion. So that question is correct.
You can report it.
You can report it. If you got more than one, you're going to get points for not taking the exclusion. It's just there for those rare cases where it just doesn't work out. Oh, this question for some reason it's not. There we go. If we are a small practice, one provider, do we still submit 1 high or 2 medium measures for the improvement activities category?
For 2018, they have not changed that for the small practice. You would still just be you'd be trying to get to the 20 points rather than the 40 points.
That is our last question.
If you need anything else, feel free to contact Scott or me, and watch in a couple of months. We'll have information out on next year, and hopefully we'll know when you have to have that stage 3 in place for 2019.
And we did record this webinar. We'll get it up on the CliniSync YouTube page here in a couple of days.
Thanks so much. You all have a great day.